Thanks for joining us for this joint American Ambulance Association Academy of International Mobile Healthcare Integration webinar. Today's presentation by Mecklenburg EMS Agency is a reprisal of their blockbuster session from the 2024 American Ambulance Association Annual Conference and Trade Show. We couldn't be more honored to have the MEDIC team here with us virtually today. I'd also like to welcome AIMHI's new Executive Director, Webinar Q&A MC, and EMS Man About Town, Matt Zavadsky of PWW Advisory Group. This session is being recorded. The on-demand link will be available on the AIMHI and AAA websites beginning tomorrow. A link to the slide presentation was included in the reminder email you received in the last hour. The slide link will also be posted to the chat shortly. The chat function will be disabled for participants today. To ask questions of JP, Dr. Swanson, and Grace, please use the Q&A function in Zoom represented by the double dialogue bubble button. This will allow you to see questions submitted by other participants, as well as leave comments and upvote your favorites. With that, it's my pleasure to turn things over to Mr. John Peterson, Executive Director of Mecklenburg EMS Agency. JP, take it away.
All right, thank you, Amanda, and welcome everyone. Good afternoon. Thank you for joining us for this webinar. Really appreciate the opportunity to share with you our story, as you will, as far as changes that we've made in our EMS system with regard to how we respond to calls. First, I want to do some quick introductions. I'll start with myself. So my name is John Peterson. I go by JP. I'm the Executive Director at MEDIC. I've been with MEDIC for about 2.5 years, and prior to that, I spent 18 years in Pinellas County, Florida, where I left as the Chief Operating Officer to come and take this opportunity here in Charlotte. I'll turn it over to Dr. Swanson, or he can introduce himself.
Thank you, JP. Good afternoon, everyone. I am Doug Swanson. I'm the Medical Director here at the Mecklenburg EMS Agency. I'm an emergency medicine physician by trade with a subspecialty in EMS, and we thank you for the opportunity to present this work to you.
And Grace?
Yes, I'm Grace Nelson. I'm the PR manager here at MEDIC. So my team is responsible for internal and external communication. So anything from the website, social media, community engagement events, and also internal employee appreciation initiatives as well.
Great, thanks, Grace. I'm going to go over some of our objectives here on the next slide, and I'm going to jump through a few slides here relatively quickly, just in the interest of time. But this is just a quick overview of the presentation today. I'm going to tell you a little bit about our EMS system and who we are and how we operate. And then we'll get into the meat, if you will, of our response reconfiguration work that we made, how we did our public outreach, what outcomes we've seen after a year now of doing this, any impacts that there's been to our patients and in our community, and then where we think we're going from here with next steps. And so I'll start with a system overview and talk a little bit about our governance. So Mecklenburg EMS Agency, known as MEDIC, is a joint government agency created back in 1996 as a partnership between Mecklenburg County and the Mecklenburg Hospital Authority. We are governed by an agency board of commissioners that is appointed by our Mecklenburg County commissioners. And each of our agency commissioners are members or representatives from each of our hospital systems, as well as the county. So the makeup is 3 representatives from Novant Health, 3 representatives from Atrium Health, and 1 representative from Mecklenburg County. A little bit about our system at a glance. So on the next slide, we have about 1.1 million residents, about 546 square miles of coverage, 72 ambulances. In the last fiscal year, we ran a little over 155,000 responses. It's going to be closer to 160,000 responses this year with 107,000 transports. We have 14 first responder partner agencies that we work with to provide EMS within the system. and 15 emergency departments. We are the sole EMS provider for 911 and the primary EMS provider for non-emergency services within the community. Our system, if we want to take a look at the next slide, our system is a public utility model. We operate utilizing system status management with a dynamic deployment system. We do have an in-house dispatch center where we dispatch our own ambulances, as well as we dispatch the county fire departments for all their fire and EMS calls. We are a secondary PSAP. As you'll learn throughout this presentation, we have a tiered ALS and BLS system that's new as of a year ago. And as I mentioned before, we do non-emergency transports. Our hospitals do critical care transports and some inter-hospital and inter-hospital campus transports. And we also operate a nurse advice line, and we utilize rideshare services such as Uber and Lyft to assist us with getting low acuity calls who don't need ambulances to their destinations that they need. Next slide. This slide's pretty self-explanatory, just gives you a little bit of an idea of our clinical performance compared to national average. Our UTSTEAM, ROSC, and survival rates are both above national average. We're pretty proud of that. Our average response times for priority 1 calls, our sickest patients, and our priority 1 trauma scene times, as well as our cath lab times. And I won't go over each of those in detail with you, but this is just a kind of an informational slide for you about our system and how we are successful. Moving on to response configuration. And so what I want to go over with you now is the why, what, when, and who. And the why is in this system in the last 5 years in particular, and really accelerated during COVID, we saw a pretty substantial increase of both our low acuity patients and high acuity patients at the same time, really creating competition for our scarce resources to be able to ensure that we're getting to our sickest patients in a timely fashion to take care of life-threatening emergencies, while also being able to handle this increase in very low acuity calls happening all in concurrently. And so we decided to take a look at the what, which is the resource type, mode, and time targets. And so essentially what it means is we wanted to make sure that we could get the right resource to the right patient in the right amount of time. And so I'm going to go over a timeline on the next slide with you of how all of that came about. But this went into effect in April of 2023. And so we're a little over a year into it now. It was a very large collaborative effort and undertaking, as you'll learn throughout this presentation. We had folks from our agency board of commissioners, our medical control board, who helped us make the decisions to move forward and how we should move forward with this. We partnered with the Charlotte Fire Department and their command staff. We partnered with all of our other first responder partners within the community, including police departments, fire departments, and county law enforcement agencies. So moving on to the timeline, this took over a year to do. It really began in October of 2021 with us starting to test what at that time we called our Sierra response protocol. And that protocol started with moving some of those lower priority calls into a 30-minute response window. And we did a lot of analysis, and it gave us a lot of data and some interesting things for us to learn, that we decided to actually expand on this and really make it an entire response configuration project. And that work began in April of 2022, progressing through different steps, notification of our medical control board and approval there, and then starting public awareness about a year later in December of 2022 with, as I mentioned before, launch occurring in April 2023. Moving on to some predictions. And so there were really 5 predictions that we had, with the number one and most important thing being that regardless of what changes we made in this system, we needed to ensure that there were no adverse impact to patient outcomes. That was the most important thing to us, understanding that we had a desire to reduce lights and sirens, reduce usage, reduce traffic accidents, look at a potential reduction of our first responder volume and improving our resource alignments. To do all of that, we wanted to make sure that whatever changes we made in the system did not adversely impact our patient outcomes. And I think you'll see that we were successful with that as we go through these slides. So we'll touch back on those 5 predictions later, and we'll see how we did on that. And for this next part, I'm going to turn it over to Dr. Swanson, and he's going to talk to you a little bit about the process of how we did what we did.
Thank you, JP. As GP mentioned, this was a long process, well over a year in the undertaking. One of the first things we did was look to see what some other like agencies out there were doing as well. This was an EMS system in Niagara and a sort of expanded response time configuration that they had developed. And we used this for some of our planning as well. We then took a look at also at where were we at the time, all of our response levels, what the time commitments were for them, where we were sending first responders, where we are not sending first responders, and develop a plan as to what we wanted our system to look like. Then came a large volume of data review for us. We went through 5 years of responses and their outcomes. This included some pre-pandemic time and some pandemic time. We looked at each subdeterminant in MPDS and looked for the outcomes of those determinants. Who was transported to the hospital emergency traffic based on their response determination. We looked at what determinants came out with closed as refusals, no patient transports, some where patients may be pronounced dead on scene, considered all the calls that we get canceled on long before we even ever arrive to the scene, and looking at that total non-transport number of each subdeterminant. And finally, we looked at each subdeterminant for what the PLSI or the potentially life-saving interventions that were performed within that category as defined by work that's been done through the National Association of EMS Physicians utilizing their definitions. The big undertaking was going through all 1,800 or so subdeterminants, each one listed in MPDS, and we developed what we felt would be the appropriate response time parameters for that determinant level based on the data that I just reviewed, who resulted in a priority 1, 2, or 3 transport, the non-transports, what patients had potentially life-saving interventions. And we had our first draft of what we thought the process would look like. We then, as JP mentioned, involved all of our first responders in this. So we asked for their feedback, solicited comments from them, where they liked the process, where they didn't like the process, some tweaks that they wanted to make to some of our determinant reviews, and did the same thing within our own provider population here at Medic. We then went back for another round of assigning determinant levels to each subdeterminant. We probably did this at least 5 or 6 times before the initial rollout of this in April of last year. A couple of projects that we tied into this because we heard very clear from our first responders partners of their concern for not responding with their lights and siren. This would be completely new. Prior to this, they were responding lights and siren to approximately 99% of their calls. So we started with individual officers on individual companies during a specific shifts and tested them on a cold response. We then went from the individual companies or officers to battalions. We then expanded it out to whole shifts, then multiple shifts, and finally tested this countywide to see that there was going to be no adverse impact to the patient. Similarly, we developed a protocol. We did this in the time of the height of the pandemic, where we, as JP mentioned, moved a number of calls to 60 minutes or to 30 minutes. We then eventually had to move them to 60 minutes. There is concern of first responders being on scene for extended periods of time, so we developed a protocol for them to become available on scene after they have evaluated the patient, had discussions with the patient, should the patient feel comfortable with that first responder agency responding to another call prior to ambulance arrival, should that need arise. Again, we started with data review, focused education with a couple individual officer companies, expanded that to whole shifts, all in a testing model, and then eventually it has now gone countywide. So just prior to this response change, this is where we were. Our matrix was now our highest priority calls, or our priority 1 responses, Delta and Echo, 1059, 90% of the time, we send a fire first responder on all those calls. Our Charlie calls were then at 1259 with a fractile response of 85%. We sent fire to all of those calls, and this is with everybody running lights and siren or emergency traffic. Then we had taken all the other calls and really put them in a 60-minute response time. And this was really out of necessity. At the height of the pandemic, as I'm sure as many were going through as well, we had as much as 25% of our workforce out of work due to exposure or illness, and had to make some drastic changes. So we were utilizing a 60-minute response target for a number of calls, with obviously at that point a non-emergent response, sometimes holding the calls in our or delaying the dispatch in our dispatch center, again, until units were available to respond to these lower priority calls. And then we have always utilized the Omega system with our nurse advice lines, the poison center, and now with a crisis response line as well. We then moved to where we wanted to be. So the plan was to continue with our Delta Echo calls, no change with them at 1059, emergency lights and siren response with first responder partners on all of those. So really no change in our Delta and Echoes. The biggest change came in our Charlie responses. And what that change was responding non-emergent without lights and siren to these. We, with that, adjusted the time from the 1259 pre to the 15-minute mark, knowing from what research has shown us that emergency response saves anywhere from about 40 seconds to 3 minutes. We felt that 2-minute average increased response time going to non-emergent status was an appropriate target. We then moved a number of those 60-minute responses back down to a 30-minute. Before we had to expand those all the way out to 60, locally they were at a 20-minute response time. We assigned those at a 30-minute, and you'll note there that with both the 15-minute target and the 30-minute target, some receive a first responder response and some do not. And I'll talk a little bit more of how we decided that on an upcoming slide. So then we still have the 60-minute for the very low level priority responses. The 90-minute you see there, that is when, as JP mentioned, our mega lines send calls back to us simply for transportation. No medical need, no medical finding, simply the patient needs transport to the emergency department because they have no other option. They have declined an Uber or Lyft, a ride share, which is what our initial offering is. And if that is unavailable, they are then in a 90-minute response. And then we have an increased percentage of calls that are first responder only. We only send our first responder partners to them. And this is from looking at all that data and knowing that on those calls, greater than 65% of the time, there is not a patient. We have no transport to the hospital. We're canceled prior to arrival or canceled on scene. And then another percentage that is results in a patient-initiated refusal. So this was our impact projection. Again, looking at that 5 years worth of data. The Delta and Echo calls, about 11%, result in a priority 1 transport to the hospital. The PLSI there, you see the potentially life-saving intervention. On those Delta Echoes, that occurs a little over 14% of the time. We then divided the Charlie calls into who receives a first responder and who does not. And a lot of that was based on, are the first responders going to have a high likelihood of impact on that call? You can see our Charlie calls where we send a first responder, it's about 6% of the time that a potentially life-saving intervention may occur. Now, that's not all first responder intervention. A lot of that is ALS intervention as well. But we targeted calls for them to go on where they are likely to have more of an impact. The Charlie calls with no first responder, only about 2.5% of the time is there a potentially life-saving intervention even performed. And again, we wanted to reserve that asset for those calls where they are going to have a greater impact in patient care. Similarly, with our Bravo response breakdown, where we send first responders and where we do not, the Alpha, which is now what we have, is that 60-minute window. You can see a very low percentage of priority 1 transports to the hospital, less than 1%. Just over 1% receive any type of potentially life-saving intervention. And so we felt very comfortable with the matrix as how we designed it. Throughout this, what we developed by having first responder only responses, which would, in theory, increase their volume, but with the number of calls that we took them out of, that we did not find that we had a need for the first responders to respond to, actually would overall decrease their volume of low priority calls. Whoop. Need to go back the other direction.
I gotcha.
There we go. This would actually decrease their overall volume, and we have seen an overall decrease in their volume. And the calls we did align as first responder only. They're assaults, MBCs with no injury reported from first party callers. You know, a lot of these are minor accidents in parking lots. The assaults are very, again, these are all without priority symptoms. So very low mechanism and a very low likelihood of actually generating a patient transport to the hospital. What we also aligned is that regardless of the response level assigned, there would be simultaneous dispatching. So even on a Bravo response, which may have a 30-minute response window, and at times, depending on how the system status is, may have a delayed dispatch, we may delay that for 5 or 10 minutes to allow the system to better have coverage. We also delayed the first responder dispatch on those calls as well, so that we were always simultaneously dispatched. We also enabled all of our first responders to have tablets in their response vehicles that they could see our CAD-to-CAD notes on the individual calls and permit them, based on the notes from the call taking, to request or to generate an increased response and go from non-emergent to emergent based on the call taking that they're reading and their impression that there was a clinical need for them to respond to emergency traffic. Back to you, JP.
All right, actually, we're going to turn it to Grace, and she's going to inform the group about the public outreach that we did. So we've gotten to this point now of determining what we need and how we want to do it. And how did we inform the public, Grace?
Well, you just heard there was so many major changes, and I knew going into it that the perception of these could be swayed to the negative pretty easily. So cue a slight panic attack from the PR team, but we knew we were doing the right thing. I just knew that it could be misunderstood. So one thing that we did that I think was key was dedicate an entire team to the communications of this project. We knew it was going to be massive. So it wasn't, we did this thing, now just post on social media and tell people. It was a much deeper strategy. So like the other teams, we did include several other agencies, fire departments, and police. So we could get everybody's perspective. Our aim that we came up as a group is right here. So we built strategies and we ensured the perspective of everyone was represented as much as possible. And we advocated for the improvements that we were making. And we drove public perception, not saying everybody was going to agree with what we were doing, but we wanted to make sure that we informed, and so everybody would know what was going on, including the millions of stakeholders, it felt like. So we'll go through all those audiences in just a second. So it was definitely a daunting task, like I said, but the framework we used for this, our main goals were to maintain oversight of communication throughout the project. Like I said, develop strategies to achieve that. And then we went back to the basics, right? So we did a communication plan. We identified our target audiences and messaging, which I'll go through in just a second. We made sure we kept a strict timeline and schedule. That was very important. We had lots of approvals and conversations that we had to have before we implemented. And we came up with a lot of tactics to do that. One thing that I think is super important that we did well was feedback mechanisms, and I'll talk through that as well. And we wanted to make sure we measured the effectiveness of that effort. So this is what I like to call my list of landmines. So we have so many people we want to talk to, and everybody has a different level of understanding of EMS in general. So we have our county boards, our town managers. Everybody has somebody else they're answering to. And we were making such a huge change and we were impacting everyone. So we looked at each of these audiences individually and talked about what do they need to know. So every message was different for each audience. These four that I'm going to go through were the same across the board for everyone. So we needed to inform everybody what we were doing, right? So the language we came up with is very intentional if you read through these. So MEDIC is improving the way the agency responds. We're going slower to calls because, you're not really that sick, right? So we're improving the way we do things. We're prioritizing our sickest patients, and we're increasing safety for first responders. And I think everybody needs to understand the why before they can advocate for this change. So we, definitely emphasize that this was necessary due to misuse of 911 system, all the things we all experience, call volume rise, and overutilization of resources and unnecessary lights and sirens responses. So what to expect? We want to make sure that the community knew that they would have more appropriate triage processes. They would experience that. And we try to compare it to the hospital ED. So this is something that's easily understood by the public, right? So they know they're going to have to wait in the ED. So why is it different for EMS? And that they should expect different response times depending on what they're calling for. Also, of course, the main thing everybody wants to know is it's safe. So we did obviously Dr. Swanson and the team, we did the testing during COVID. We had lots of data that we put together to prove that it was safe as well. So how are we going to get this across to the public? And we did a lot of prep work in the back end. So we put together a lot of that data to show why. We knew we were going to have media requests, social media posts. So we put together some new photographs and video resources as well, and graphics. We went through talking points for media. So again, if I need to sit down with these reporters and explain what we're doing, we made sure we had talking points for whoever they were speaking with. Then obviously the never-ending presentations that we did, we built those as well. these are my favorite things I think that we did for the websites. So we built a landing page for the public. That's pretty self-explanatory. We had all of our key messaging. We had, if we did any videos or presentations that were recorded, we posted those. Any community meetings we did, we made sure that information was there as well. And a contact form. We also did one internally. So when we launched this, we knew our crews and fire departments as well would have questions and wouldn't, they have a call, they thought, they should have been going lights and sirens and they weren't. Why not? That type of thing. So we had an outlet for them to ask questions and we would give real-time feedback after we reviewed the calls. So that ended up, I think it was definitely effective as far as buy-in for our employees and fire departments. We did lots of presentations and we made sure we did community feedback sessions. So we went through our county commissioner district. So we made sure we hit all of those. We did a traditional media plan, so interviews. Once we did our first public presentation, we made sure we were prepared for that. Had lots of news stories from those. And we also engaged with our city's community relations committee. They really helped us. They connected us from 311 had messaging that they helped put out, and also diversity initiatives. So Spanish materials, things like that. We also went through and made sure we hit a lot of demographics. And then we did the organic and paid social media as well. And we did Nextdoor for the first time. Obviously, Facebook, Instagram, and Nextdoor ended up being a good platform as well. After all that, so we did 16 formal meetings and presentations. That doesn't count updates in between. I think JP and I were talking the other day, and I think we did at least over 30 probably different PowerPoint versions. We ended up with 37 news stories. About 150,000 people reached on social media in various ways. We had 800 public landing page visits, 400 first responder landing page visits, and we had 100 response inquiry form submissions. So our employees asking questions, fire department asking questions, we had about 100 of those. And I'll just want to point out the headlines from those news stories and how they could have been super negative really easily. So medics going slower to calls. But what you see, the work we put in helped, I think, turn these headlines into something more positive. So medics plan to change response times based on urgency. Those things. So it wasn't, salacious and, everybody's in an uproar. It was more, oh, that makes sense. This is what they're doing. So just to wrap my portion up and point out the positives and what I would do differently or what I'm doing moving forward. I think the effective stakeholder communications, having a team dedicated to this was so important. There were so many holes we could have fell into with this. And public perception was everything. And I think collaborating with within those teams as well was key, and having those outlets for employee feedback too. What I would do differently, the community meetings, I think we probably all experience that a lot of people don't have a complaint about EMS until they experience something. So nobody was going to go to these community meetings. They weren't very well attended. So I would probably do, I would recommend for anybody else doing something similar to do virtual options as well. And just be prepared that you might not get the response you'd like. Also, we ran into if they weren't involved with medic previously, so if they weren't a member of our board or with the county, then a lot of the city officials, they just didn't know enough about medic to make an informed opinion. So I think there's opportunity there for us to work on that avenue coming off of this initial change. And then obviously we're going to keep those key messages alive. It wasn't a one and done campaign. This is something we are incorporating into any presentation we do, any training we do. How does medic work? Because it does work so differently now. So I think that was definitely a labor of love going through it. But we definitely learned a lot. And after all that, now a year into it, we have lots of outcomes to share with you guys.
Yeah, thanks, Grace. So I'll talk a little bit about the outcomes, but as you can see, it was a pretty monumentous effort of communication, trying to make two-way communication too, so that not only could we talk about what we're doing, why we're doing it, why we think it's safe, but to hear feedback from people too, and to try to make changes or improvements based on that feedback. And I'll talk a little bit about that in an upcoming slide. But this first slide here, specifically about our changes with regard to lights and sirens usage in this system. When we looked at the data, we found that we were responding with lights and sirens to 75% of our calls prior to making these changes. And of that 75%, only 4% of those calls actually resulted in a lights and sirens transport to the hospital. So that alone there is a very disproportionate, showing that many, if not most, of the calls that we were responding to with our lights and sirens on were not necessary to be doing that. So we predicted that through these changes, we could reduce our lights and sirens usage by about 72%. And in reality, it's actually been about 68%. So we're pretty much right on that prediction, or very close. And today, we are responding to 22% of our calls with lights and sirens. And of those 22%, 12% are transported with lights and sirens for life-threatening emergencies. And so it's a much better ratio of lights and sirens use to lights and sirens transport. And so we feel very happy with how this has resulted for this community. Yes, we could have actually probably brought our lights and sirens usage down even more, but we felt that we found just the right spot based on everything that we'd learned over the course of this process. Moving on to discuss call volume. And so we also did some predictions with all these changes, with changing the response times in all these different new categories of response times. We wanted to do some estimation of what we thought as far as the percentage of calls and how that would align. And so I'll use the 15-minute window on this slide as an example. So this was the vast majority of our calls. These are Charlie calls. And prior to the response configuration changes, about 49% of all of our calls went into that Charlie response window. And we predicted that with the changes we were making, that would significantly change to about 18%. Where it actually landed was about 31%. So still a pretty significant change. And you can see the rest of the numbers here. I won't go through them all, but this is something that has been interesting for us to learn and see how the system has changed pre and post as far as where the calls are aligning within the response windows that we've created. We've learned a lot from that, and we'll continue to monitor that as we move forward. Moving on to first responder impact. So as was mentioned previously by Dr. Swanson, in fact, it was the most frequent concern that we heard from our elected officials within the community. As Grace mentioned, we did 16 public meetings. We did a presentation at every city council and town council in Mecklenburg County and at our Mecklenburg County Board of Commissioners meeting as well, to go over with them what we were doing and an opportunity to gather feedback and answer questions from those folks. And the number one concern that we heard was a worry about impact to our first responders, specifically that if we were going to go slower to lower acuity calls with the fire department responding, that they would get on scene first and then have to wait for an extended period for the ambulance. And there was concerns obviously about that, where that unit would be tied up and not able to respond to other high acuity calls coming in. That's where the protocol that Dr. Swanson went over earlier that allows those crews to go available on scene if they need to came about. but really it's the simultaneous dispatch piece that we predicted would actually make that concern very minimal. And so what we found is a year into this, the impact of an increase to wait times on scene for fire departments is only about 44 seconds. And the reason for that is because they're dispatched the same time the ambulance is dispatched. And so that's what really made all the difference there. The other thing that Dr. Swanson was talking about earlier too was that a combination of doing more first responder only responses, but also doing less unnecessary first responder responses. And so we worked with our first responders to determine what calls that they go on where they make a difference, where they can really make an impact to the patient, and ones that maybe they don't, and they would be better off being available to respond to higher acuity calls. And after we ironed all of that out, our prediction was that the call volume for the fire departments for EMS calls within Mecklenburg County would go down by about 10%. And in reality, it's been 17% reduction in EMS response volume for our fire department partners, which has been great because it's now providing them with more availability to be able to respond in their community for either higher acuity EMS calls or fire calls or hazmat calls or other types of important calls. Moving on to traffic crashes. So one of the things that we predicted and that we were very much hopeful that the changes that we were making, particularly with the reduction of lights and sirens use, we had hoped that that impact would reduce our traffic crashes, and it indeed has reduced our number of traffic crashes by about 33%. And I actually anticipate that over the course of the next year that percentage will actually increase. It's a relatively low number of crashes per month if you look at the per month average. So one crash can really impact it, but I do think that overall we're going to see this number get even better. But that's a significant change. When you think about if you could reduce your crashes by a third, and the impact that has not only to our employees and our first responders on our ambulances, our first responders on the fire trucks who've made a decision to go less calls with lights and sirens, and to our motoring public as well. It just makes a lot of sense in my mind, at least, to be able to provide an increased level of safety to our people and to our community if we can. And so far, over the course of a year, that has proven to absolutely be the case here at Medic. I'm going to turn it back over to Dr. Swanson now. And so I went over the operational impacts, and Dr. Swanson is going to talk to you a little bit about patient impacts as a result of these changes.
Thank you, JP. So yes, throughout this process, we have reviewed every one of those low priority responses, those responses in the 30 and 60-minute windows that generated an emergent or a lights and siren transport to the hospital. We review 100% of those. And comparatively here, the year prior to this reconfiguration, that rate was about 0.6% of 39,000 calls in that low priority to priority 1 transport. Post configuration, that number is about 0.95%. So less than 1% of the time does a low priority call generate a priority transport to the hospital. Each one of those, as I mentioned, gets reviewed by either myself or I have 2 of my former EMS fellows, one that works in each of our healthcare systems, Novant Health and Atrium Health, that review the outcomes on all of these transports. And we do not find that there are any patient impacts, adverse impacts related to the response time. So we continue to feel that this is very safe, as even more so if you consider that of that 0.95%, those that had a response of less than the 1059 fastest target, that number is even lower because we were able to better manage the system, have assets better positioned to respond to calls. We can be within that target window and not have any adverse outcomes related to the response time. Next. So as I mentioned also early on, we provided the crews with the opportunity to initiate an upgrade from a non-emergency to an emergency response if they felt there was something that they read in the notes that gave them a clinical concern, or if their ability to respond that call was going to be impeded and it potentially would have a clinical impact on the patient, they could upgrade from non-emergent to emergent response. That occurs now about 3% of the time. When we first rolled that out, that number was 10%. But I think as crew chiefs, both on the ambulance side and the first responder side, have seen that there are no adverse outcomes in these cases, that number has continued to decrease, where we've gone now from about 10% to 3%. And of those upgrades, about 10% of the time when they upgrade, do they actually even end up with a priority transport to the hospital. At 12% of the time. You can see that a number of those upgrades, still 16%, result in a refusal. The top two upgrade types are when it's an unknown or for the traffic accidents. And one of the things we did early on was adjust our response to traffic accidents that occur on our major freeways. So we have 3 highways that go through Mecklenburg County: I-77, I-85, and I-485. We have a couple expressways. And for first responder and PD partner safety, as well as patient safety on the scene, wanting to get people taken care of and out of highways and freeways in a increased fashion, we have upgraded those call types. One of the concerns that was expressed to us from a couple of our county commissioners was, what's going to happen to cardiac arrest survival if, in their mind, we slowed down to some calls by not going to emergency traffic? Were we not going to have as good outcomes? Well, again, remember, we did not change the Delta and Echo responses. We did not change that. So we continued to perform very well. We receive in all comers. So this is every cardiac arrest, even those that are expected deaths, traumatic circulatory arrests, all comers. We achieve ROSC about 35% of the time, which is higher now post-configuration than what we had pre-configuration in the year prior. Similarly, there was a concern that, well, we would find, sort of the thought was there'll be more dead bodies, was how it was expressed. And we don't see that. We do have a protocol in place that permits termination of resuscitation on scene following prolonged efforts. But we also see that in the year preceding and the year following, there has been no significant change into the number of patients that are being pronounced on scene. We do not see that, because we are responding to a higher percentage of calls in a non-lights and siren fashion, that has led to any type of increased mortality. And again, actually, it's a decrease in total count and a decrease in the percentage during this time.
All right. Thank you, Dr. Swanson. So going to do some evaluation of the next steps, kind of where do we go from here. But first of all, I want to revisit those 5 predictions that we talked about at the beginning of the presentation. And I think what hopefully you've seen throughout the presentation is a confirmation that there has been no adverse impact to the patients or to patient outcomes as a result of these changes. there's no bodies in the street, if you will, as that's been referred to before. We have absolutely improved our resource alignment based now on patient condition, not just by who calls 911 first. We were successful in reducing our lights and sirens responses and subsequently reducing our traffic crashes. And also a significant and even better than expected reduction in first responder EMS call volume. And so we check off the boxes there on those. As Dr. Swanson was mentioning, as we move on to changes post-launch, and this is the slide I was referring to earlier, we've learned some things, like, for example, the protocol change of upgrading to calls that are on the interstate for safety reasons. That is something that we have found that made sense to do. But through the employee feedback mechanisms that we had, and one of the things that we did, and I think Grace touched on this, but we actually put QR codes in the ambulances so that all our crews had to do is scan it with their phone, and then they could give us feedback on a call if they had a concern. And we learned from that. We learned from our first responder partners that gave us feedback. And we actually made some modifications, and happy to report that most of the modifications we made to the process were minor, but that highway responses is one, and some other standard operating guidelines that ended up being outdated needed to be upgraded to correspond with the changes that we made. We did go back and reclassify 6 call types into higher priority responses. So there were 6 call types that we realized from feedback that we were getting from our crews in the field that we felt, okay, this type of call really ought to have a faster response. And so we took that, what we learned from that, and moved those calls into a faster response, and that has been going very well, and subsequently modified 32 sub-determinants to help us make sure that we were really getting the right resource to the right patient in the right amount of time, as I mentioned at the beginning of the presentation. And another important thing, and this is something that you need to consider if you're looking at doing this, is we discontinued the practice of dispatching an ambulance prior to understanding the patient condition. So some of you might call that a pre-alert, where you get a call and pretty much as soon as you've got an address, you're dispatching an ambulance with lights and sirens and they just go. We don't do that anymore, and you really can't do that if you're going to truly triage and understand what calls should or should not receive a lights and sirens response. And so that's just something that you need to take into account, that we have been working through and still to this day are working through as part of our process. Moving on to challenges and lessons learned. We've talked a little bit about the political landscape and first responder reception. And I think this is a point where, I can say we're reporting a lot of really positive things here, but not everything has been rosy. This is very difficult, very time-consuming work that not everybody in your community is probably going to agree with or understand. There's a lot of barriers of education and getting people to understand not only we found about what we're trying to do, but even understanding who we are as an agency and what we do to begin with. There's still a lot of misunderstanding in our community, and I'm assuming in probably other communities, about what we even do and the services that we provide as EMS. And so that's something that we've learned from and are working towards. It's really helped our first responder relationships as far as hearing and getting more feedback, and we still get feedback from them on this even a year later. When a call happens, they go, ooh, I'm not really sure that I like how that happened, or that customer service level that we provided, or I have a patient care concern as a result of this. We look at every single one of those to make sure that there's not something that we missed, or if there's something that we think that we need to improve. And this is going to be in a continuous improvement process, I think, not just for the short term, but for the long term, as we continue to grow as a system and change and learn. And when it comes to internal culture changes as well, it was a major change. And there was somebody had asked me a question of, are we going to have employees that quit because they no longer get to respond lights and sirens? And that's kind of the fun part of the job. And what we found is actually quite the opposite, is that I think our people really have a respect for the fact that we are taking their safety into account, and that they only need to respond with those lights and sirens when they need to respond with those lights and sirens. And so that actually was nice to see. And as far as our controller processes, there was a lot of challenges going through our communication center, huge changes for them, a lot of education and training that happened, needed to happen on that. And I think we have a question on that, so I'll wait till the end to dive deeper and answer that question specifically. So what's next? We're not done. There's more to follow here. Part of this system change was tiering our system from an all ALS system to a BLS and ALS tier. That was a major change. This system was specifically designed as what was then known as a high performance all ALS EMS system. And we really have changed that and implemented our BLS service. And our BLS service has operated and is operating outstanding. It has been an excellent change so far, in my opinion, to this EMS system. Let me tell you a couple things that have been some significant improvements. Prior to fully implementing our response configuration changes in April of 2023, for a few months prior to that, 6 months or so prior to that, we started putting BLS units, maybe 5 units on to test and see how it would work. At that point, we were at a maximum of about 194, around 200 responses per week with our BLS tier. And since implementing that, we are out now closer to 1,000 responses a week with our BLS tier. And so that has taken a tremendous burden off of our ALS units. I'm going to show you some KPI metrics on UHU here in a little bit. That shows how that has helped ease some of that, especially with our ALS units. But moving on, and actually the KPI is the next slide. So perfect, roll right into that. So with regard to our system UHU, you can see back in March of 2023, we were having some of our highest system UHU that we've ever had in this system. And with implementing BLS, implementing the response configuration changes that we made, getting better control over how we respond to calls, it actually has helped reduce our UHU. Now, a caveat or an important piece of that too is our staffing is improved, particularly on the EMT side. We are still short-staffed on paramedics, but a combination of staffing, BLS, and all of this work has really helped us reduce our UHU there. And you can see on the chart on the right what we call our unit hours produced. So this is our ability to put unit hours on the street has significantly increased as a result of these changes and a result of being able to get more EMTs in here to help create a very robust BLS 911 tier here. So that's been great. And then on the last slide here for KPIs, there's just this is kind of a things to know, this first part here, and it's kind of it's common sense, I guess, but I'm just going to reiterate that if you make these changes where you're going to go to lights and sirens on fewer calls, means you're going to have longer response times, which means your assigned to arrival time is going to go up, and so likely as well is your total task time. Those are things that are going to be important for you to factor into your specific EMS system of how is that going to potentially impact my unit hour needs and my personnel needs and things like that. But one interesting that we've seen is that once we've now sort of gotten this system right-sized, got the BLS tier in place, yes, our arrival times are up, and they're going to stay up and probably continue where they are if you see that step there on the left. But if you look on the right, our total task time is actually starting to come down, and this chart is actually a couple months old. It's actually continuing to decrease and move in the right direction now. And so we're very encouraged with what we're seeing with our task time. Really, if you look at April of 23 versus today, there has been virtually zero increase in task time comparatively. So with that, I want to thank each and every one of you for your time and listening to us for the past hour or so. And we will now take an opportunity to answer any questions that you might have.
JP, Dr. Swanson, Grace, amazing presentation. We have great questions that have come in from the team. So I'm going to run through these and you guys can decide who's going to answer the question. I think you addressed Cynthia's question first about how you trained the medical dispatchers. One of the things that was curious, and I didn't hear it mentioned, is Bobby Hopewell asked a question about patient satisfaction. Obviously, Bobby from the EMS survey team, great partners of the industry. What has been the patient's perspective, their reaction to some of these longer response times? What have you seen from a patient experience perspective?
Yeah, so we didn't want to do anything different as far as isolating, patient satisfaction responses. So we just made sure that we maintained our normal level of monthly patient experience satisfaction and monitor that. And what we've seen is it's steady. We have not seen any decline in patient satisfaction. We also haven't seen any specific increase in patient satisfaction. So I would be able to say that there's been no change to our patient satisfaction based on what we get from our regular patient satisfaction surveys, which are done monthly.
Awesome. Another question. So every metric that you set out, every prediction that you made came true. And quite frankly, clinically, operationally, safety perspective, the system is functioning even at a higher performing level as a high performance EMS system. Is this a model? Is this something that you've done that you feel should or could be implemented in EMS systems across the country to help improve safety, improve patient outcomes, and quite frankly, improve financial sustainability of EMS systems?
Yeah, thanks, Matt. So I think every EMS system, especially you've heard that phrase, if you've seen one EMS system, you've seen one EMS system. We're all unique. Each community has different needs, different abilities, different funding mechanisms. But I think that this model, I think absolutely could serve as a model to do just those things that you said, Matt. If not in its entirety, at least in certain pieces, right? You've learned there was a multifaceted changes that happen here. And you don't have to do everything that we did. If there's something that maybe we've done that you think could be good in your community, then I would encourage you to look at that, look at your data, analyze it, ask questions about it. And then if you think you want to make a change, to go through that process and make sure you involve all of your stakeholders.
Man about EMS, industry icon Rob Lawrence asked a question early on, and how did you deal with the naysayers? There are always going to be people who are, as you said earlier, who were resistant to the change. I'm sure that continues to some extent, but maybe Grace, as you did your community education, how did you address or help calm the fears of those naysayers who were really against this change, truly feeling that, as we've said before, you'd be stacking bodies like cordwood at City Hall by county administration by changing this model?
Yeah, I think we were very careful, number one, with all of our messaging. So talking about the safety, have data to back it up. We also, I think, did a good job with recording any meeting we had. What were the concerns? We just kept records of those and tried to make sure we had all the information, any other presentation moving forward. So I think just proving them wrong, right? So no, we know what we're doing. It's safe. Here's the data. And now a year later, we were correct, right? So I think it's just moving that along. And JP, feel free to chime in because I think you got the brunt of the naysayers as well.
I did, but I think Dr. Swanson has his hand up, so let's let him jump in.
Yeah, sure. One of the things we were able to do is we've had some follow-up meetings with some of those naysayers to show them some of this outcome data that, no, it is operating extremely safe. We're not seeing those concerns that you had. Additionally, when we went into this, we had nearly a year's worth of suddenly putting people into a 60-minute response window in the height of the pandemic without any community consultation, without notifying the public, and we reviewed those cases, and there's no adverse impact in any of those cases. And simultaneously, we didn't hear complaints from the public about, hey, I got an ambulance in almost an hour. Well, yeah, those complaints didn't come through, and that was with no messaging whatsoever. But I think in part just being, as Grace mentioned, proactive about it, that we're tracking this data, we're reviewing this data, we continue to do so, and had offered it if we saw anything hiccup, we would reverse what we were doing. And we have not seen that.
Yeah, and that's a good soundbite, is that, the expectation of the caller and your folks. I think JP, you had shared earlier that one of the things that your call takers do is when through the EMD protocol, QA'd, ACE accredited, MPDS system, you give the caller the expectation that, hey, we're planning to be there within the hour. If anything changes, call us back. So it's very safe, and that helps set that expectation. Another question that has come in, and actually coming to you live today from the ABC 360 conference in Clearwater Beach. This comment came because we've been talking a lot about Medic at this conference, so kudos to you guys. Did this change impact your revenue at all? Because we've heard from folks in the past that, well, if you change this, then fewer calls are going to be able to be billed as emergency, and you go to a tiered system where you're doing BLS and ALS, it's going to impact your revenue per call. What has been the impact on the revenue stream as a result of these changes?
So that is a great question. And the answer is it has not had an impact. And the reason why has not had an impact is because in this system, as far as how we bill for ALS versus BLS, we had already made that change. So even if we were sending a paramedic ALS unit out to a call and it was a BLS transport, you're billing it BLS anyway. So there was no change in that. It's just now we actually have a better alignment of sending a BLS resource to those calls the majority of the time instead of an ALS resource. And we've seen no impact. It's worked very well for us.
Terrific. Colby Miller from MedStar Ambulance or MedStar Services in Michigan asked a great question. Any time analysis in your red light and siren responses versus your non-red light and siren responses overall, not just from the patient outcome perspective, but what has been the big difference in a light and siren response versus a non-light and siren response in your system? Do you know that offhand?
Do you mean as far as like an average response time for those calls?
I believe that's what he's asking. Yeah.
Yeah. So our priority one average right now is I think about 8 minutes and 48 seconds. And our priority two is right around 14 and a half minutes. And I don't remember the rest off the top of my head, but we're hitting the mark on both of those metrics. The 15-minute mark is the hardest one to make, especially when you have traffic and things like that. And we only increased that by 2 minutes. And so that's been the biggest challenge, if you will, for that. So definitely something you need to consider in your system and your environment and your traffic patterns and how far you got to go for calls and things like that. But we are starting to see, especially now a year into this, we're starting to see, especially on the priority one, times start to decrease, which is good. And that's the impact. I think another year from now, we'll have hopefully an even better report there.
Right. And Dwight DeMarsh asked, was there a change in your electronic patient care reporting system part of this change as well?
It was not. We did not need to do that. However, we are just by happenstance in the middle of doing a complete change over of our EPCR system. But that's not a result of this program. That's just actually because we're due for a new system.
Awesome. And Brad from Tele 911 sent in a great question: do you have any future plans or strategies to continue to improve your system and enhance your service level?
We do. So there's a couple of things that we want to look at as what I call response configuration 2.0. One of those things is continuing to evaluate our nurse triage and how we utilize that, just determining, is it working to the best of our ability? Are there more calls that could go through nurse triage? Could we make that more robust? But one of the things in this particular EMS system that we're really going to focus on this year is we have, if you notice at the beginning, I mentioned 155,000 responses, but 107,000 transports. So there are many calls in this system that we are responding to with an ambulance with 2 people on it that don't result in transports. And so my next look is we will be evaluating this year potential quick response vehicles that would be something, obviously not an ambulance, with some other type of personnel. All of this is still to be determined. Not sure if this is a direction we're going to go, but I want to know, is there a way that we can send an alternative resource to those patients that just need someone to come out and they don't actually need an ambulance transport to a hospital? And then that takes it into the next steps of community paramedicine or something like that we do not currently have here at Medic, telehealth and how we can leverage that, and other things that we've learned from ET3 and other things that have been happening over the last couple of years. So yes, there's a lot more to come. And it's a little too early to tell how it's going to look, but those are some of our thoughts.
And a fun part of that, JP, is, as you may know, when I was at MedStar, we negotiated a payer agreement with a commercial payer that actually agreed, and we have a contract in place now where they will pay us to respond a QRV, a quick response vehicle only, to a clinically appropriate emergency medical dispatch triaged alpha level, low transport percentage, and they'll reimburse us using CPT codes for responding to a call like that without an ambulance, to lay hands, eyes, do an assessment. So we can even figure out the reimbursement model that says you'll still get reimbursed if you don't send an ambulance, because the reimbursement rate may be lower than if you send a full ambulance, and payers are willing to look at that now as part of this whole EMS transformation. So kudos to you guys for doing that. So just looking to see if any new ones had come in. We got Brad's, looks like Jason. Oh, I know there's a question about rural. Do you have any rural areas in your community, and did you not do some of these changes because of distances that responses might take?
So good question. There are some areas in the very outskirts corners of Mecklenburg County that today you could maybe consider rural, but really we're mostly suburban and urban, and almost all of our growth now is happening in our suburban communities, which have been expanding like wildfire over the last 10 years. Challenge with that is we still have the rural road infrastructure that now have these huge suburbs with all these neighborhoods that are being built up on what used to be pasture. And so while we're much less of a rural community now, we have those kind of impacts. But to answer the question about how we respond to those areas, the way that our system is set up is we are responsible for, we'll use our priority 1 responses as an example, 10 minutes, 59 seconds, 90% of the time, countywide. And so that's just the whole conglomerate countywide. Doesn't matter where it is in the county, that's where we have to be. But then our system is also divided into zones. We have a north zone, a central zone, and a south zone. And there's different compliance metrics in that by zone as well. And that helps to kind of isolate some more of those areas. That's actually also in process of being potentially revised as well, as the system has changed a lot in the last 30 years. And so I hope that answers your question.
I hope so too. It was a great answer. Another question regarding financial sustainability. I know when we did it at MedStar and transitioned from all ALS to tiered deployment, one of the metrics that we used was the cost per unit hour overall. Have you seen a difference, or have you tracked a difference in the ALS cost per unit hour, BLS cost per unit hour, and maybe even globally across the system? And has that reduced some of your expenses?
Yes, and so that's part of considering the long-term growth mitigation with this and going to a tiered system, and potentially looking at QRVs as well, right? Because that would be significantly cheaper than sending an ambulance to those calls that don't result in a transport. We can't get paid, right? But we've seen it is a little bit lower for cost per unit hour for BLS, but not a lot. Really, mostly we're looking in the cost, like looking at the cost of salaries for that. In this system and with state of North Carolina rules, we actually keep all of our ambulances ALS capable. And that way we can make it ALS or BLS whenever we want, however we want. We could have a supervisor, paramedic jump on a BLS unit and take it to the hospital with everything they need. So it's, as far as the cost savings there, it's relatively small, mostly, if not primarily, salary based. Yeah.
Yep. Okay. Two last questions as we wrap up and let people get back to their day. First is Jason asked a question about your interaction with rideshare. So how does that work? How do you integrate with the rideshare programs that you mentioned earlier?
So I'm sorry, Matt, say that. Can you say that one more time?
Sure. So the rideshare component that you have, you mentioned that you used Uber, Lyft, rideshare for some of these outcomes. How is your interface with that? How does that work?
Yeah, so any of our calls that go through the Omega process actually go from our dispatch center to either our Novant hospital or Atrium hospital system. They both assist us with providing a nurse line. We send those calls to them. They will triage the call. If after it's determined through the triage process that they don't need an ambulance, they can offer that caller a rideshare service. We actually cover the cost of the rideshare service. It costs on average about $16. But $16 to someone in a rideshare versus sending an ambulance out at $260 an hour, makes a lot of sense to me to do. And it's been quite successful for us. We have seen about a 50% increase in the use of that over the last couple of years. It's still a relatively low number or percentage of calls, but it helps.
Yeah, and as there's more acceptance of that, it could have a higher utilization. Okay,
Yeah.
we're going to ask one last question and maybe a lightning round for both Grace, you and Dr. Swanson to answer this question from your perspective. So what would be your number one piece of advice if one of the participants or the person who's going to watch this video asynchronously tomorrow, the next day, a week from now, what is the one piece of advice that you would give them as they begin to embark on wanting to do the same thing in their community that you guys have done? We'll let ladies go first. So Grace, what would be your response to that question?
I would say, just like the naysayer question, have the data ready, like have all of your homework, ducks in a row. Do I just have to have one? I want one more. Make sure, I think, involving all of the stakeholders like the fire and police, anybody it affects, involve them in the planning, and that you would have so much more buy-in that way. Even if they don't agree with everything, they will understand. And
thanks. Dr. Swanson, how about you? What would be your clinical advice for that one or two things that people need to do to start thinking about doing this?
Yeah, sure. So some of it's the same. Continue to track the data, look at the outcomes, and be open to making adjustments here and there as needed, as we have done, where we've changed the response from a Bravo to a Charlie, from a no first responder to with a first responder. Wherever we found as going through the outcomes and looking at the data that, hey, we should probably benefit here, and be open to making adjustments. This is, when we fired this live, it was not set in stone. I would never keep it set in stone and just see what happens. I would make it very fluid, especially in the beginning.
Thank you. And JP, how about you? Final piece of advice or two.
I would say the most important thing is relationships and relationship building prior to, during, and afterward. If you don't have good established relationships with your first responder partners and your key stakeholders in your community, it's going to be that much harder for you to make a big system-wide change and recommendation like this. So got to have those key relationships in place and some trust there with those folks. Continuing that through the process with open communication and transparency, and then continue that process afterward. And if things don't work well or things need to change, to own it, and just to come forward and say, we hear you, you're right, we're going to change it. And I think that's the key, and we continue to try to do that to the best of our abilities today. And I think that's the number one thing.
Excellent. Folks, tremendous job on the webinar, tremendous job on educating the people about the future of our profession. Kudos to what you've done in your community. It is truly something that we should all be modeling. Excellent process, excellent outcomes, and bold. So thank you for being bold. Amanda, as the primary host of the webinar, are there any closing comments or instructions that you want to give our attendees about next steps in the webinar itself?
So in the reminder email for this session, you received a PDF copy of the slides. The slide PDF as well as the recording will be posted to both the AAA website and the AIM-HI website within 24 hours. Because this session was simultaneously streamed to Facebook, you can actually access the playback right now on the AAA Facebook page. But to echo your previous comments, we thank everyone for joining us, and we look forward to seeing you on a future AAA, AIM-HI, or hybrid webinar in the future.
Hey, and the next one is going to be really cool coming up for the AIM-HI folks. They're conducting a great webinar with many of the folks from agencies on working with the TikTok generation, and that'll be coming up in July. So when you're on the AIM-HI website and others, register for that, because that's going to be a very fun webinar, because we're going to have many TikTok generation panelists on that next webinar. So really looking forward to that. And thanks for Medic for being part of that one as well. So with that, we'll close. Thank you guys for attending. Look forward to working with you and doing some more work in the future. Have a great rest of the day.
Yep.
Thank you.